Hi, everybody. Welcome to the podcast on the knee joint. This will be the last one I'm doing for this semester. As we know, the knee joint is quite a large joint when we look at the two condyles, or the four condyles between the two particular bones. So we can say it's the largest synovial joint in the body. Also, it is the largest weight-bearing surface. If we think about the hip joint, how much weight it carries everything above it. Well, the knee joint carries the weight of everything above it. So being that it's a little bit farther down, it does carry a lot of weight. It is a hinge joint, although some authors do call it a modified hinge, and we'll get into that a bit later. It does allow for flexion, extension, and in the flexed position, some rotation. So it's minor, but it's there, and you're going to take that in your assessments class as well, but it has to be in the flexed position, not in the extended position. The patellofemoral joint is a gliding joint, so that's between the patella and the distal end of the femur. And there is a non-articular area on the tibia, which is found within the intercondylar area between the condyles, as we know was the intercondylar eminence. The knee relies very much so on the strength of the muscles and its tendons that cross it for stability and for reinforcement of the capsule. So if we remember the distal femur, we had two condyles, and we also had two separate condyles of the proximal tibia, and then we had the patella, which sort of is related to all. So therefore, because of that, we can say that the knee joint has three articulations within the joint capsule. So there is the medial tibiofemoral between the medial condyle of the femur and the medial tibial plateau and the meniscus that's related to it. Our second one is the lateral tibiofemoral between the lateral condyle of the femur and the lateral tibial plateau and its meniscus. And of course, the third is the intermediate patellofemoral, which is between the patella and the femur, which we can see here. We've got our lateral here. We know it's lateral because the fibula is out here. So we have our lateral condyle here with the lateral plateau of the tibia. And then we have our medial here with our medial plateau of the tibia. And of course, the patella sitting in front here. You can sort of see it lying here as well. There are extrinsic and intrinsic ligaments when we look at the knee. So there are 5 ligaments that help make up the capsule. When we look at them as being intrinsic, if you remember correctly, this is about fibers that are shared with the fibrous capsule of a joint. So we can say here that these 5 thicken the capsule or are thickenings of the capsule. They are also known as external ligaments to differentiate them from ligaments which are internal to the fibrous capsule. Something that's kind of unique to the knee is that we have deep inside ligaments that are related to the knee, but they're internal to the fibrous capsule in the space between or deep within. So the patellar ligament. So when we look at the quadriceps muscles, which we'll be looking at shortly, the tendon of the 4 quadriceps come together just proximal to the patella, travel downwards and do surround the patella, and travel down to the tibial tuberosity, of course, which is on the anterior superior part of the tibia. There are some authors that believe that above is the patella or the quadriceps tendon, and then below the patella is the patellar ligament. Either way, it still seems to be a continuation of the quadriceps. So the patellar ligament runs from the apex of the patella to the tibial tuberosity. Remember that the patellar apex is on the inferior part. And of course, as we know, the patella is a sesamoid bone found within the quadriceps tendon. Medial and lateral expansions of this ligament are called the patellar retinacula and merge into the capsule on either side. So we have these widenings that come out here, so we can see them, sort of widening out on either side, forming here. And we can see how the patella sits within them. So again, as I said, some call the quadriceps tendon above and then the patellar ligament below the apex of the patella itself. The superior part of the ligament is separated from the synovial membrane by an infrapatellar fat pad, and the inferior part of the ligament is separated from the tibia by the deep infrapatellar bursa. So we can see that there is a bursa sort of up here and below, and we'll get into those bursa just a touch later. We know that any kind of hinge joint has collateral ligaments. In this case, the knee is no different. It does have collateral ligaments. We fundamentally call them lateral or medial collateral ligaments, but the terminology has changed somewhat based upon the bone that they're associated with. So both obviously do arise at the distal femur, but then go on to different structures distally. So the first, the lateral, is called the fibular collateral ligament, and it's cord-like, and it extends from the lateral epicondyle of the femur to the head of the fibula, hence the reason why the fibula kind of has that pointy top on it. It does not attach to the lateral meniscus. So the one thing to take away is that the fibular collateral ligament runs from the femur to the head of the fibula, but does not have any connection to the lateral meniscus. It is separated from the lateral meniscus by the tendon for popliteus. So we can see here is the tendon for popliteus here, and that the fibular collateral ligament runs again from the femur to the head of the fibula. And you can see there is no association to the lateral meniscus at all here. You can sort of see the popliteus tendon here kind of running underneath it as well. This tendon for popliteus then passes deep to the fibular collateral ligament. This ligament also splits the tendon of biceps femoris. So biceps femoris is again another muscle we'll be taking here shortly, and it is a two-headed muscle that is found as one of the hamstrings as it comes around. The superior portion of this fibular collateral ligament is part of the fibrous capsule, therefore considered to be intrinsic, and the inferior part of the ligament is separated from the capsule by fatty tissue, therefore considered extrinsic. So we can see here how some intrinsic sharing here, but down in here there's a fat pad that sort of fills in the space here. The other is the medial collateral ligament, but known as the tibial collateral ligament because it attaches to the tibia. So where the fibular collateral is more cord-like, the tibial collateral is a flat band. So it's a strong flat band from the medial epicondyle of the femur to the medial aspect of the condyle or shaft of the tibia. Its fibers are, deeper fibers are firmly attached to the medial meniscus. So the lateral collateral or fibular collateral does not attach to the meniscus, but the deep fibers of the medial or tibial collateral ligament does attach to its medial meniscus. It is considered to be actually partly continuous with the tendon of another muscle known as adductor magnus, which we've talked before. It is crossed by the tendons of the pezanzarine, gracilis, sartorius, and semitendinosus. And this is what helps strengthen the medial aspect of the joint. So again, from a REMX perspective, trying to help a knee that's got some issues and needs some strengthening, these three muscles, gracilis, sartorius, and semitendinosus, need to be considered when doing a rehab program. So here we can see the tibial collateral flat attaching down onto the shaft of the tibia here on the medial condyle of the femur. And we can see how there are shared fibers here with the medial meniscus, where of course the lateral collateral does not attach at all. And we can see the popliteus tendon here. What do? They assist to prevent excessive rotation of the tibia, especially when the joint is in flexion. It does resist varus and valgus stresses at the knee. And I'm pretty sure you may have taken that. If not, you will be. Varus and valgus are, valgus is knock-kneed, so knees in towards each other. And then, of course, varus would be the exact opposite with the legs wider apart at the knees. These ligaments do become very taut on full extension, but do allow some rotation in the flexed position. So they're not as taut when the knee is flexed, which therefore allows for it. The next is called the oblique popliteal ligament, and it arises from the posterior medial aspect of the medial condyle of the tibia, and it passes superolaterally to blend with the fibrous capsule, and it is an expansion of the tendon of semimembranosus, and this helps strengthen the capsule posteriorly. So here's our oblique popliteal ligament that we can see here, and here running in behind. Remember, here's our lateral collateral here, or our fibular collateral. And we can see the popliteus muscle here coming around and separating that fibular collateral from the joint capsule. But we can see here how the popliteus muscle is a continuation of semimembranosus as it comes through here and runs on this oblique angle on the posterior aspect of the knee, thus providing some strength to the posterior knee. And it does allow for, it does blend with the fibrous capsule posteriorly. The arcuate popliteal ligament is a Y-shaped ligament. It passes over the tendon of popliteus, another muscle, into the posterior capsular fibers, and it arises from the head of the fibula. So we can see the arcuate is right here. So our arcuate is this one here, running from the head of the fibula across this way. So we have the oblique popliteal running this way, and then we have the arcuate running this way, kind of this Y shape, separating. So from the head, it's singular, and then separates into to attaching to both two aspects of the oblique popliteal ligament. It does blend with the posterior capsular fibers, of course, helping to stabilize the posterior knee. So again, it's nice to look at this picture because it kind of blends everything together. So here is our oblique popliteal ligament here posteriorly, tendon of adductor magnus that we can see here. Here is our medial collateral ligament, again, attaching to the medial meniscus inside. Here is our lateral collateral or fibular collateral ligament here. We can see the bursa that lies underneath, and then of course below that would be the fat pad. Here is our tendon of semimembranosus here that does provide some tendons to this this posterior oblique popliteal ligament. And then we can see here is our arcuate here, this Y-shaped ligament in behind here, and we can see popliteus runs underneath it. This puts it all together as well. Again, medial collateral, semimembranosus. We can see the oblique popliteal here, the arcuate ligament here. Everything's kind of creating this very large, thick, fibrous capsule, which then, of course, because of its thickness, becomes tendons on the posterior aspect, thus supporting the posterior aspect of the knee. The capsule itself has is a superior part of it extends from the articular margins of the femur to periphery of the menisci. So think of the superior part of the fibrous capsule extends from the articular margins of the femoral heads to the periphery of the menisci. Its inferior fibers of the inferior fibers of the fibrous capsule from the menisci to the tibia are called the coronary ligament. So from the fibula, from the distal femur to the periphery of the menisci is called the fibrous capsule. And then from that point, inferior fibers of the fibrous capsule, from that then meniscus to the tibia. So from the distal parts of the femur to the menisci is the fibrous capsule. And then from the menisci themselves, inferiorly is known as the coronary ligament. This fibrous capsule is incomplete. It consists of extensive tendinous expansions, some capsular fibers with intrinsic ligaments, and of course deficient laterally, which allows the tendon of popliteus to pass out of the joint. The anterior aspect is really made up of the patella ligament, and the patella retinacula. So you can see it all sort of coming together here. The joint capsule is in blue, and we can see here is, again, the fibrous capsule up here, and then these coronary ligaments, sort of this part down here running around like so. The synovial capsule is the most extensive of any joint. It does have several extensions that pop out of the joint, out of the fibrous capsule. Also many recesses which help form bursae. There are at least 12 in the knee that, of course, we've got many structures crossing over between the two, and we need these bursae to be there to sort of help in protection. Antero-inferiorly, it forms what's known as a suprapatellar pouch for full knee flexion. So we do need this looseness in this suprapatellar pouch, so we can see this part kind of hanging down here. We can see it when we look at the patella here. We have this pouch kind of running here, and this what allows for a bit of that looseness, allows for full knee flexion. It posteriorly passes in front of the cruciates, so that the cruciates are intracapsular but extrasynovial. So the two cruciates that are in here, the crossing ligaments, they're within the joint, but they're not bathed in synovial fluid from the synovial cavity. So we can see here we've got the pouches and they again allows for the flexion. Of course, as I said previously, there are tendinous reinforcements. So anteriorly to the joint, we've got the patellar tendon and the quadriceps tendon, or the patellar ligament and the quadriceps tendon. Anteromedially, we have the anterolateral patellar retinacula. Anterolaterally, we have the iliotibial band, which we've talked about previously. And medially, of course, we have the pezanserine, gracilis, sartorius, and semitendinosus. Posteromedially, we have the semimembranosus, and posterolaterally, we have the biceps femoris. So as we said previously, there are at least a dozen bursae of the knee, so we're going to go through the ones that are important to us. The first we're going to do are the ones that are the communicating bursae. Now these, remember, because they're communicating, they either connect to or are part of the synovial membrane of the joint itself. So the first is the suprapatellar bursa, also known as the quadriceps bursa. It is an extension of the synovial cavity between the femur and the tendon of the quadriceps as it comes down towards the patella, and this allows for full flexion. It is held in place by a few fibers of vastus intermedius called articularis genus, and you'll be taking those in terms of muscles. So we can see here is the bursa here as it's coming down. Again, the suprapatellar bursa, and you can see how one of the quadriceps just tend to hold it in place. We can see the suprapatellar bursa here as well in red in this diagram. The next is the popliteus bursa. Of course, that popliteus muscle we talked about that goes underneath the fibular collateral ligament. It extends from the tendon of the popliteus to the lateral condyle. It opens into the lateral part of the synovial cavity inferior to the lateral meniscus. So we can see it here in the posterior aspect, sitting approximately here. The next is the medial gastrocnemius bursa, and this is also an extension of the synovial cavity, and it runs deep to the tendon of the medial head of gastrocnemius, which of course is the muscle that you see that you call the calf muscle. So the sort of medial gastrocnemius, we can kind of see back if you over on the other side here. Semimembranosus bursa is located between the medial head of the gastrocnemius and the semimembranosus. If this gets very inflamed and becomes quite enlarged, this is also known as the Baker's cyst. Now the non-communicating. So this means that they're sort of standalone and they are where they are. So the first is called the prepatellar bursa, also known as the subcutaneous prepatellar bursa. This lies between your skin and the anterior surface of the patella. And this allows the skin to glide over the bursa in flexion and extension without, irritating the anterior, irritating itself on the anterior surface of the patella. It can it too can also be inflamed after prolonged weight bearing on hands and knees. And when it does, it can present as a soft fluctuant swelling just anterior to the patella. This used to be known as the housemaid's knees, but roofers, floor installers, those sorts of things, they can notoriously get it. So we can see it sort of right here, the prepatellar bursa sitting right on top of where the patella is, that we can see here. The next is the superficial infrapatellar bursa. So it's also known as the subcutaneous infrapatellar bursa. This too lies between the skin and the tibial tuberosity. So we've got to come all the way down to the proximal tibia, where the quadriceps tendon finds attachment at the tibial tuberosity, and this lies between the skin and the tibial tuberosity. And this too allows the skin to slide over that tibial tuberosity in flexion and extension as well. It comes under pressure, of course, when kneeling with the trunk upright, and when inflamed, the subcutaneous infrapatellar bursitis used to be known as clergyman's knee, because of course when a clergyman kneels at church, they're not bent over like flooring, they're sitting completely upright on their knees. So we can see it here is the superficial patellar bursa. Here's the tibial tuberosity here. Quadriceps tendon coming to the patella, quadriceps or patellar tendon or the patellar ligament coming down here to the tibial tuberosity, and we can see the superficial patellar bursa here between the skin and the tibial tuberosity. There's also the deep infrapatellar bursa. This is located between the patellar ligament and the anterior surface of the tibia, and it is separated from the joint by the infrapatellar fat pad. And when it's inflamed, there's swelling laterally to the infrapatellar ligament. So we can see that this deep infrapatellar is right here, lying just around this fat pad that we see lies anterior to the knee joint, but posterior to the patellar ligament here. So we have the superficial patella lying on the superficial surface of the patellar ligament, and the deep patellar lying posterior to it or deep to it. The Pezanzarine bursa, so all three of those muscles that make up the Pezanzarine are sartorius, gracilis, and semitendinosus. This Pezanzarine bursa separates the Pezanzarine insertion from the medial surface of the tibia, so it tucks underneath where the three meet. The last one is the iliotibial bursa, of course, which is between the beneath the attachment of the iliotibial band as it crosses over to attach onto the fibula. So as we talked about before, cruciate ligaments not cruciate ligaments, but the distal femur and the proximal tibia. As we know, we've got a flat platform or the plateau with a round ball sitting on top. So we've already talked that we've got some modifications that help with that, such as the menisci, which we'll get to a bit later. But another thing that is in here are these cruciate ligaments. And the reason they're called cruciate is because they cross each other. So therefore, there's two in each. Now, when we look at the synovial capsule, they're within, because they're deep in the knee, but they're outside the synovial membrane. So they're surrounded by a synovial membrane, or in a compartment surrounded by a synovial membrane, but they contain no synovial fluid around them. So they're within the knee, but they're not within the joint, or within the synovial space, I guess is the best way to put it. They are very strong. They're rounded bands, and they cross each other obliquely. They're located between the medial and lateral condyles, and they're named according to their site of attachment on the tibia. So we have to remember that. So in terms of there's an anterior cruciate and a posterior cruciate, they are named according to their attachment on the tibia. Now, we need them absolutely because they're essential for anterior and posterior stability of the knee, especially when we're flexed. So we can see here in this diagram, we can see here is the tibia here, proximal tibia. Here's the anterior part here. There's the tibial tuberosity. So obviously the anterior cruciate comes here anteriorly, hence its name, anterior cruciate. And then the posterior arises from the posterior aspect of the proximal tibia, hence the reason why it's called the posterior cruciate ligament. And you can see how they're going to cross each other from anterior back and from posterior forward. We can see them in their position here, both an extension here on the right and flexion here on the left. So the anterior cruciate is the weaker of the two. It arises from the anterior part of the intercondylar area of the tibia, just posterior to the attachment of the medial meniscus. So we can see it here posterior to the medial meniscus, and here in this area, in this intercondylar area that we can see here. It extends superiorly, posteriorly, and laterally. So it goes from the anterior part of the tibia, travels upwards and backwards to attach on the posterior medial aspect of the lateral condyle. So because it's coming from the anterior part of the tibia and traveling upwards and laterally to attach onto the inside of the lateral epicondyle of the femur, so therefore the posteromedial aspect of the femur. It is slack when the knee is flexed and taut when the knee is fully extended. In other words, it prevents anterior displacement of the tibia on the femur. So in extension, with this ligament, this anterior cruciate ligament, the tibia cannot move forward. We do a test called the anterior draw sign, which you'll learn in semester 3, where we actually do pull the tibia towards ourselves to see whether or not it's being held in place by this ligament. So here we are, here the anterior cruciate in its place. Here's the tibia, anterior here, of course, the patella and so forth. We see anterior here, right? Anterior here and crossing over to go from a bit medial anteriorly to the medial aspect of the lateral epicondyle, so traveling back and laterally to attach onto the medial aspect of the lateral epicondyle. The posterior cruciate is the stronger of the two. It comes from the posterior part of the intercondylar area of the tibia. It too travels superiorly and anteriorly though, so where the anterior cruciate passes superiorly and posteriorly, the posterior cruciate passes superiorly and anteriorly, and it attaches on the anterior part of the lateral surface of the medial epicondyle. So the anterior cruciate travels upwards and backwards to attach onto the medial aspect of the lateral condyle. The posterior cruciate goes upwards and over medially to attach onto the lateral aspect of the medial condyle of the femur. This ligament prevents posterior displacement of the tibia on the femur. So anterior cruciate prevents the tibia from sliding anteriorly, and the posterior cruciate prevents the tibia from sliding posteriorly in relationship to the femur when the knee is in extension. This is the weight-bearing, in the weight-bearing flexed knee, this ligament is the main stabilizing factor. So what do you think of something you might do with a flexed knee that's weight-bearing? And one of the things is stairs. So when you step down at 90 degrees to bring your foot on the step, you actually are weight-bearing in the flexed knee. So you can see here is the posterior cruciate here, coming from the posterior aspect here to travel medially to find attachment on the lateral aspect of the medial condyle of the distal femur. We talked about this before. We all know what a menisci is. It's fibrocartilaginous. It's wedge-shaped, and it makes a non-concurrent joint more congruent. So when we look at the menisci in the knee, they're very thick at the peripheral edges, and as it travels medially towards the internal parts of the knee, it gets thinner and thinner until it just completely doesn't exist anymore. So as we know, menisci fill in gaps between two bones that are incongruent. So in this case, we say it fills in the gaps between the tibia and the femur to create a more congruent joint surface. In doing so, it also creates a deeper articular surface. So we can see here how it deepens it by running around like so, and allows those femoral condyles to fit into a nice deep area where we get a more congruent joint. So here's our tibial tuberosity. Here's the anterior cruciate ligament traveling backwards and laterally. Here's the posterior cruciate here that's going to travel anteriorly and medially. And we can see how this lateral meniscus is round, or the menisci are around here in orange in relationship to those cruciate ligaments. So let's do the medial meniscus first. It is said to be semicircular, and it's not completely a circle. So it comes around circularly. So we can see it here coming around. Okay, so this medial one, see it coming around, but there's ligamentous tissue here. They don't come together to form a complete circle. They form like a semicircle, shall we say. And here's our medial meniscus here in the cadaver. You can see how deep it is and how it comes around and forms almost a C shape. So the anterior horn attaches in the intercondylar area of the tibia anterior to the anterior cruciate ligament. So we can see here, from what I can see here, I do believe it's anterior here, but we can see it here as well, and it's anterior to the cruciate ligament. The posterior horn attaches to the tibia anterior to the posterior cruciate ligament. So anterior to the posterior cruciate ligament that we can see here, and we can see here in its position with the anterior cruciate ligament, or the anterior cruciate ligament. As we said, it fills in the gaps between the tibia and the femur to create a more congruent joint surface. And it creates a deeper articular surface. So, why my mouse is acting up, I do apologize. Okay, come on, we lost it here. It's where my mouse is running backwards, I apologize. Okay, it has an attachment to the capsular fibers. So remember, the medial meniscus does attach to the capsular fibers and also attaches, if you remember, to the medial collateral ligament. And so it has attachment to the capsular fibers, to the medial collateral ligament, and to the outer margin of the tibial condyle via the coronary ligament. This is why when we have knee injuries, especially on the medial aspect, the medial meniscus can get involved because it's so attached to many structures that lie outside of it. So if they get damaged or strained or pulled, the medial meniscus is coming along for the ride. So we can see it here kind of semi-shaped. The lateral meniscus is the smaller of the two, almost circular but not quite. The horns attach close to each other on either side of the intercondylar eminence, and it is attached to the joint capsule, to the tibia via the coronary ligament, but not to the fibular collateral ligament. Therefore, it's more mobile when we look at it as compared to the medial meniscus. So we can see the lateral meniscus is here, and you can see here is the fibular collateral ligament here, and you can see in the drawing the spaces here, and they don't touch each other. Of course, they do deepen the joints area, as we said, but they also do help as shock absorbers. They do help in lubrication and nutrition of the joint. They do reduce friction, and they do improve weight distribution as it comes down the femur into the knee joint itself. Attaching from the posterior aspect of the lateral meniscus to the medial condyle of the femur is the meniscofemoral ligament. So we can see here the meniscofemoral ligament. Where are we here? Here Here we go. Here's the meniscal femoral here. We can see how it comes around and helps maintain that lateral meniscus in place. So the attaches from the posterior aspect of the lateral meniscus to the medial condyle of the femur. Here to the medial condyle of the femur. The transverse ligament of the knee it connects the two menisci anteriorly and allows them to move together when the joints are moving along. So we can see here the transverse ligament is here, which keeps them moving in coordination with each other when the knee is working. The tendon of popliteus, which I've talked about a couple of times, it does attach into the lateral meniscus and is thought to assist in posterior movement of the meniscus during flexion of the knee. It does separate the meniscus from the fibular collateral ligament, which we've talked about here a couple of times. Here's popliteus here as it comes around, and you can see how it associates to the lateral meniscus here, separating it from the lateral collateral ligament or the fibular collateral ligament. The infrapatellar fat pad, I sort of alluded to before, it is deep to the patellar tendon. It's lined with a synovial membrane, and in doing so, it helps spread lubrication over the joint, especially when we're moving into flexion and extension. So we can see it all in here. There's a large fat pad here. Here we can see the anterior cruciate ligament. Here we can see the medial meniscus. Here's the patella here with the quadriceps tendon here, and then the quadriceps ligament, or the patellar ligament here, and the fat pad fills in all this space. Of course, movements of the knee, it is modified hinge, flexion and extension, and as I said, in flexion there is some rotation. Now in the final 15 to 20 degrees of extension, the tibia actually rotates externally and it screws home the tibia, okay? So the tibia rotates externally, which screws it or tightens it into the two femoral condyles. And we can see here, if it's still working. So when we watch the movement here, you can see how it moves in and out. I'm going to replay here. Oh, commercials, I apologize.
There's an incredible arthritis story going viral about a guy named Toby who is like pushing 70. It's crazy.
Okay, watch this. You can see that it's going to screw in when it gets into extension. So you can see it's slightly rotated.
Hi, welcome to the video Restoring Screw.
Sorry, I don't know how to end up back there. As you can see the screw there that it's moving across.
There's an incredible arthritis story going.
So obviously the knee is designed for weight bearing, but its function is commonly impaired. Of course, stability depends on the strength of the surrounding muscles. So from a rehab perspective, if we want to get the knee nice and strong, we have to start working on all the muscles that cross it. And of course, we've got the pezanzarine, we've got the hamstrings, we've got the quadriceps. They all have to be strengthened to further stabilize the knee. Thanks for this. As you know, Jen will be teaching some of the class. Sarah will be teaching some of the class. This is just to add on to give her a little more space to get done what she needs to get done. Thanks again. Oh no. Oh no, oh no, 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 no.